after soft tissue reconstructions. As we know, the normal shoulder is the most mobile joint in the body. It enables to put the hand in various different range of positions. And the motions in the shoulder is in two planes. One is between the humerus and the glenoid, and the other one is between the scapula and chest wall. The average range of motion is about 170 degrees flexion, 80 degrees external rotation, internal rotation to T5 segment, and cross body or horizontal adduction is about 14 centimeters from between the humerus condyles and the anterior part of the acromion. Glenohumeral ligaments acts as a passive restraint to excessive range of rotation and translations. And shoulder stiffness often results from contractures, scarring, and shortening of different regions of the capsule. When rotator interval involved, it might limit the flexion, extension, and the external rotation. Anterior inferior part of the ligament limits external rotation and abduction, and posterior inferior ligaments limits internal rotation and forward flexion. Different causes, which you can divide into humeroscapular, as mentioned before, frozen shoulder, postoperative problems, and post-traumatic, and also osteoarthritis. And there are some problems in the scapulothoracic region, which might include sternoclavicular or acromiclavicular joint osteoarthritis, muscle contractures, fractures of the rib and scapula, some tumors, and so on. Stiffness after soft tissue surgery is almost inevitable, and we see it in shoulder replacements, after rotator cuff repairs, and even stability repairs. And what we see oftenly, it's edema of the tissue surrounding the joint, inflammation or capsulitis as a result of scarring formation and thickening inside the capsule. Some other abnormal mechanics, like if surgery is not managing to perfectly align the humerus head inside the capsule, or when there is imbalance with tightening rates among the different parts of the capsule. A study to see what's the histological change in the capsule. There was placement from 42 patients and 3 control patients who had glenohumeral instability non-traumatical, and they were treated with laser-assisted capsular shift. The samples were collected from the anterior inferior glenohumeral ligament. The controls, as mentioned, were 3. They collected 14 patients before treatment and 14 directly after the treatment, 16 specimens in about 6 months, and they had 6 stiff shoulders after an average of 6 months. They saw before treatment there were no histological changes, and up to 6 months there were inflammatory reactions. After 6 months, the healing was occurred and the tissue returned almost to normal. In the stiff shoulder group, they saw persisting highly reactive appearance and focal proliferation of the synovial cells. And this indicated that the clinical signs were consistent with the histological findings. There are many types of acquired stiffness or postoperative stiffness. Those which includes the capsule, like after capsular shift or Bankart repair, and those extra-articular, like during a cuff repair, if you have a shortening of the tendon, adhesions between the tissue planes, or it might be skeletal, or if there is an incongruency in the articular surfaces. Incident, a study retrospective view of 58 patients, 64 shoulders with cuff tear. All of them were operated by one surgeon, both arthroscopically and with mini open surgery. They divided the tear into three groups, small, less than 1 centimeter, and medium, 1 to 3 centimeter, and large, 3 to 5 centimeter. This was the groups, and they had the same rehabilitation, a follow-up of 6 and 12 weeks after surgery. They saw the group with mini open repair, they had 14% less range of motion, while the arthroscopical group, no patient has deficient in range of motion. Another study, 72 patients with arthroscopic repair of the cuff. So 3 patients had stiffness, which required a second procedure with the capsulotomy in about 6 months after surgery. And they saw during these surgeries that there were evidence of synovitis and thickening of the capsule. And 2 of these 3 patients had diabetes. Burkhardt, in a review of 489 patients, they had 24 patients, about 5% with less range of motion, and total healing after second procedure with capsulotomy later. And they indicated some risk factors, which were calcific tendinitis, adhesive capsulitis, single tendon tear, pasta repair, and age under 50, also having a workers' compensation insurance. In a Bankart repair, stiffness is less common. It mostly occurs in the plane of external rotation, and when you do excessive tightening of the rotator interval, it leads to less external rotation. And the long-term consequences when you do tightening of the anterior capsule and the subscapularis tendon, it might lead to a posterior shearing of the humeral head on the glenoid surface and a potential articular degeneration, which we saw before with putty plat or Magnusson stack procedures, which is almost not done today. And in a study in Sweden, they showed that external rotation is significantly better with arthroscopical repair than open Bankart repair. In another study, showed that there was a linear association between the degree of loss of external rotation and patient satisfaction. There was a risk for being dissatisfied with almost double for every 10-degree less postoperative external rotation. I said the most common long-term complication of instability surgery is degenerative change of the joint. Gilles Wallish in 570 patients were operated with different kind of stability repair at mean of about 6 years after surgery. They had about 9 to 20% arthritis in glenohumeral joint. Another study, 30 shoulders with Bankart repair, 29 years follow-up, they had 40% arthritis. This showed that the Bankart is not preventing osteoarthritis in the joint. The clinical evaluation, it's important to observe the loss of motion both in active and passive way. And the motions must be compared with the contralateral side. The pain should be eliminated with local anesthetic, and the testing in all directions, flexion, abduction, external rotation, and horizontal flexion. And also always compare both passive and active motion. Should carefully measure the isolated glenohumeral motion, because most of the patients with stiff shoulder, they have some kind of compensatory motion from the scapulothoracic part of the shoulder. And active motion might be tested when the patient is seated, and the passive motion is measured in supine position to lock the scapula. If you have loss of active motion but preserved passive motion, it might indicate a failure of cuff repair or sometimes nerve injuries as axillary or suprascapular nerve. But loss of passive motion and good strength after cuff repair, it might indicate postoperative adhesions, capsular contractures, and sometimes incongruency of the articular surface. That's why the pattern of motion loss is important indicator of the location of the adhesion. For example, loss of external rotation with the arm and the side may associate with contracture of the rotator interval or the anterior superior region of the glenohumeral ligament. Stiffness after cuff repair can be attributed to either pre-existing comorbid conditions such as osteoarthritis, which might be missed before operation, or it may be due to operative techniques like tight closure of rotator interval, overtension of the tendon, inadequate tendon mobilizations. And also, it might be due to postoperative rehabilitation. We prefer to immobilize the shoulder after surgery just to protect the repair. And often this leads to a stiff shoulder. So passive range of motion in the first weeks is very important. There are some things to observe is low tolerance for pain is a risk for shoulder stiffness, because when the patient has pain, they don't want to move the shoulder. And also some other clinical observations like atrophy of the muscles, residual impingement, AC joint and biceps pathology, nerve injuries, and defects of the deltoid muscle, which often are iatrogenic, especially after open surgeries. Investigations to do a plain X-ray radiography, which might demonstrate the extent of resection of the acromion or AC joint. And you might detect untreated os acromial or a fracture of os acromial, and even unrecognized osteoarthritis in the joint. Arthrography might be done. It will not give a lot of information, but you might see the repair of the cuff, but you cannot see, you cannot get any information about the capsule. MRI is very useful. You can see the healing of the tendons, thickness of the capsule, thickness of the rotator interval, muscle condition, and if there is a repeated tear after a repaired tendon. Treatment should be directed to the cause. Close manipulation is not appropriate for postoperative stiffness because there might be more extensive adhesions involving different planes of the tissues, and it may pose a risk for the original operation which is done before. Arthroscopic release is a better way to release the adhesions between the tissue planes, divide the shortened capsule, or do Z-plasties for the shortened tendons. After that, you should have a gentle, controlled manipulation, and also treat the concomitant subacromial and interarticular diseases. Postoperatively, it is important to relieve the pain. Oftenly, it is good to use interscalenic block either by catheters or intermittent injections. And it's important to begin with a direct passive range of motion. Some contraindications, malunions of the tuberosities, which is causing osseous blocking, or a severe osteoarthritis. You will not get a good result with manipulations. We have done a study on patients complaining of subacromial impingement with or without osteoarthritis of the AC joint to see if they can affect the capsule of the joint when we see some patients complaining of pain after operation. We did MRI and clinical evaluation with constant scoring before operation and 3 months after operation, and even a clinical evaluation 6 months after surgery. We have collected the data, but it's not analyzed yet. So we are waiting for the results. Thank you very much.